Hello, everyone. My research project is about addressing the gaps in hypertension management in Black Americans. This project is not only personal to me as a health science major, but also um, this issue is something that plagues my family on both sides as well. So without further ado, I'll get into the inspiration that I got for this health topic. So for this topic, like I just stated, I got inspiration from this, particularly from my mother's side of the family. My mother's side of the family is from North Charleston, South Carolina. It is part of the Low Country. It's geographically basically the coast of the Carolinas and southern Georgia. It is very much known for its cultural influence and its food, which is diverse in seasonings and ingredients. A couple that you may have heard, some not so familiar, red rice, hoppin' john, okra, shrimp and grits, all delicious food, but unfortunately, these are not foods that you should consume on a daily basis as they are very calorie dense. Many of these foods are made with sodium, salt, butter, saturated fat, just things you don't want to eat on a daily basis. But yet, these foods are very important to the communities that live here and are essential to their identity. Now, regarding my relatives, there are many relatives on my mother's side that suffer from hypertension. My own mother, for example, I can't remember if she suffers from hypertension or pre-hypertension, but it's definitely one of the two. My grandmother and all of my great aunts suffer from hypertension, to which they do take medication for to help them manage it on the short term. However, being a health science major and learning about the effects of chronic disease and what can be done to help manage it, it led me to wonder if, with medication, would other holistic methods to care, such as um, counseling, behavioral therapy, nutrition education, etc., in combination with medication, would be even more effective for controlling hypertension, as my main career interests lie between nutrition and health psychology. Hypertension is definitely a problem that is plaguing the United States, and it's clearly not an issue. It is clearly an issue that is not getting better. According to the American Heart Association, over half of Black Americans in the United States have hypertension. And an additional fact that I learned from my research was that hypertension is being diagnosed much early, sometimes as early as the late 20s or even early 30s. So that was clearly interesting to me. Just thinking, I never really stopped to think just how serious of an issue this was and how many Black Americans this issue plagued. So typically when it comes to hypertension care, if you go to the doctor, they will typically give you a test and then they will recommend some form of pharmaceutical treatment, which in short term works. And under this, it's delivered usually through the biomedical model of care. Now, for those who may not know what that is, to put it bluntly, the biomedical model views the body as a machine, and malfunctions in the machine, whether it be injuries, disease, whether it's chronic or not, or sickness, causes that machine to malfunction and needs quick fixing immediately to get it working again. So, as a result of that approach, singular approach, again, the individual isn't really recognized. The biocycle, social aspects, if you will, go overlooked or neglected. Things like dietary habits, behavior, cultural aspects, emotional wellness, those are basically thrown out the window under this model of care. And I feel like if hypertension care switched to a more holistic or integrative care method, that would yield more positive long-term results. So out of my literature review, I found two sources that I felt were most impactful. regarding my stance on this issue. The first one by Schoenthaler et al. They conducted a lifestyle intervention, a large lifestyle interventions among Black churchgoers in New York City for about 11 weeks. So there were two groups in this randomized trial of about, I want to say 300 to 400 participants. The group receiving this treatment, they received motivational counseling and therapy along with, excuse me, standard health education for around 11 weeks, whereas the other group received solely health education, and that was it for 11 weeks. For the group that was getting the faith treatment, local health advisors that resembled the population were used to help build trust and also to help with engagement. After the 11 weeks were done, the authors realized that participants in the faith study clearly had greater hypertension control rates, which proves that individualized, culturally attuned care results in more positive blood pressure control rates. Additionally, it reinforces the need to honor an individual's life context and culture. I feel like the main reason why this group had so much success was because this intervention considered their emotional and spiritual wellness. It targeted their emotional wellness through, like I said, behavioral counseling and therapy if needed, but it was also conducted at a church, which of course addresses spiritual wellness, and it helps Black Americans feel both emotionally secure yet socially connected as well. The second resource by Holt et al., this was from the American Board of Family Medicine, I believe. Authors discovered that between Black and non-Black patients, physicians were practicing race-based prescriptions. After dozens of studies, they realized that this prescribing method was not improving hypertension rates in Black Americans. And furthermore, by putting Black people into this monolith, if you will, and not really breaking it up into diverse groups such as Black American, Caribbean Black, African immigrant, etc., this can overgeneralize care and oversimplify it. And as you know, that isn't effective because even within the Black diaspora, people can have unique experiences with health, unique viewpoints regarding health and preferences as well. Excuse me. And it also reinforces the idea that care needs to be tailored to an individual's life experience in combination with medication. Okay, so now we can get into my interviews. Here's some background information regarding my two interviewees. The first one, Mary Johnson, she is a family friend. She works at the Women's Medical Center in Charlotte, North Carolina, and she is a deputy commander of patient support services, along with being a RDN or registered dietitian nutritionist who frequently works with Black patients. The second interviewee was my mother, Dana Henderson. She is a stay-at-home mother to her 20-year-old autistic daughter, who has been diagnosed with hypertension for about 5 years now, both of which were conducted through an online Zoom meeting. So for Mary Johnson's interview, she discussed that she first developed an interest in working with this community very early. She noticed that a lot of her family members who often died young from hypertension, even with medication, this is what sparked her interest, not just in nutrition, but also in healthcare. And it led her to think, similarly to me, are there any other ways with medication that could possibly help reduce hypertension rates, or at least for those who have hypertension, help control it long term? She also addressed whenever she does work with patients who want to change, or for those who may be slowing a bit in their motivation towards that long-term positive results, she always asks them their why, because often she describes that if we don't feel motivated to change, or maybe we start out with the willpower to change, but the results aren't immediate, then it can be hard to move on. So, an example she gave that she heard her patients often say, um, their why would be to perhaps see their children, to see a grandchild graduate high school or college, or to get back into the hobbies that they loved doing, or getting into activities that they used to enjoy years ago that now they can't now due to their hypertension, but anything of that sort. That is why she asks their motivation to change before she goes forward with their treatment process. Um, She also noticed that many of her patients were quite health illiterate regarding food labels, and that's something that she addresses whenever whenever they have concerns with that during the patient visits. And she often will give them notes as well, written in simple language that they can understand, to help them understand what is best for their diet. Another thing that I also found interesting was how a lot of her female patients, particularly women of color, suffered chronic stress or daily stress. She believes this is because women are often told, especially in Southern culture, to put everybody in front of you, which as a result can cause women to neglect themselves, not rest, and not take care of their health, which she said was important. So, as a result of that, she expressed her desire for the addition of psychosocial support with hypertension care, as obviously, if one is put in an environment with constant stressors, then that can make hypertension very difficult to manage, even with medication. Regarding the effective treatments that she's noticed has really helped her patients, she said the DASH diet, which of course is a type of heart healthy diet that emphasizes low sodium and low fat foods, improving sleep quality. She said many of her patients have extremely poor sleep quality, which she said could of course make or break hypertension. And additionally, like I said, regarding psychosocial support, she does refer them to therapy if she feels that their stress is impeding their progress, or if their progress is stalling in general. Additionally, something she also does too is cooking classes. These cooking classes not only empower Black Americans to take advantage of the information that they learn, but it also is very respectful to Southern culture, as I think a lot of us think when we think any sort of diet, we think of foods that we just think of foods that we can no longer enjoy, like fried chicken, hamburgers, potatoes, etc., etc. She says the reason she has these cooking classes is not only to share nutrition information, but also to show that just because you need to eat healthy, it does not mean you have to sacrifice your favorite foods or certain seasonings. She shares alternatives. There's alternative ways to cook these foods, alternative ingredients you can use, alternative spices, etc. And she has found that that has been very effective regarding hypertension control rates among her patients. When asked if she could redesign healthcare regarding hypertension management, she expressed how she wished that there were more wellness institutions everywhere in the community regarding stress, exercise, relaxation, etc., instead of just fast food being on every corner. As of course, in many communities, especially low-income Black communities, this is unfortunately a very common thing. So she said the addition of that, I feel like, would really help promote individuals to better their health. Additionally, she expressed her wish for alternatives in grocery stores. While they may be in stock on the shelves, she says that these food options, for example, fried chicken or perhaps even vegetables cooked a certain way, they're never really front and center. I remember she was explaining how at a local Publix she was looking for some alternatives. I believe it was baked chicken and another food item, but the fried foods were just front and center. out there first. And she said, I feel like if they had the alternatively cooked food options like boiled, baked, steamed, for example, if those were also out front and center, it could help empower Black Americans or just individuals in general to make more healthier choices regarding their diet. As for my mother or Dana's interview, prior to being diagnosed with hypertension, she expressed having constant headaches. However, at the time, of course, she was a stay-at-home mom, so she just assumed that this was just the daily stress with just being a parent. However, one day she did finally make an appointment, and her previous provider diagnosed her with hypertension. Unfortunately, when she was describing this healthcare experience, it was not positive. She described her provider as not showing a lot of eye contact, open body language. It was very closed off. And she spoke in a very kind of rushed tone, almost as if she was behind schedule, if you will. But in her words, she said it felt more like an office meeting or even just a checklist, a rundown of a typical visit. And as a result, she felt like she couldn't explain any questions or concerns that she had with her care. And when she was diagnosed with hypertension, the provider just pretty much gave her a bag of medications and sent her on her way without explaining any effects or did not even consider to ask about her life context as well. So as a result of these repetitive negative experiences, she decided to look elsewhere for care. Her current provider now, from her interview, is much more positive. As she said, her experience was much more positive. She experienced more open communication, and her provider treated her as an equal regarding choosing a treatment plan. Her lifestyle was taken into consideration, such as any daily stressors, daily routine, uh, physical activity, etc. And what she liked about this doctor was how she also encouraged the use of other holistic methods to care alongside medication. So, as a result of these positive visits, Dana now implements various tactics that she has found have lowered her hypertension, such as physical activity, monitoring sodium, or using just seasoning alternatives when cooking, and even faith involvement as well. All of which she said has reduced her stress, which in and of itself, of course, helps lower blood pressure. At the end of the meeting, she expressed wishes for how physicians should have follow-ups with their patients at wellness centers or wellness checkups, if you will, to help check on their progress regarding whatever treatment they decided to go to regarding hypertension, sorry, or to address any questions or concerns that may pop up during this treatment process. Because she feels like she said, I'm more than just my diagnosis, and I want my care to reflect that, if you will. And something she also expressed openness to was, once again, kind of like Mary Johnson, psychosocial counseling. And she said that this was what she thinks is a very vital component to hypertension care, especially being a caregiver to a 20-year-old autistic, her 20-year-old autistic daughter who requires round-the-clock care every day. So if she goes down and she's not feeling well, then of course that's going to affect the care of her daughter as well. So regarding results from the interview, both women shared communication and cultural gaps in the management of hypertension in Black Americans. Something I thought was very interesting was how they both expressed the addition of psychosocial care into hypertension management, which I feel like further reinforces my idea that hypertension management cannot just focus on medication. It has to address a person's cultural well-being, their cultural identity, their emotional states, any chronic stressors that they may deal with, what they're eating, etc. So like I said before, both agree that care needs to acknowledge the entire patient in their life context, not as just a diagnosis in treating the symptoms, if you will. And additionally, the addition of non-pharmaceutical approaches. So whether if it's the motivation to keep going regarding management or stress from caregiving, I feel like these strategies are essential to positive long-term hypertension management. So now we can move on to solutions for hypertension management. The primary purpose of these two solutions are to really prevent breakdowns in communication regarding patients and providers, because I do feel like that can make or break not just long-term health outcomes, but also if whether or not the patient or the provider will engage in the healthcare visit. And additionally, it helps tailor these treatment methods to a community's intersectional identities. In this context, it would be towards Black Americans. So my first solution was culturally tailored interventions, particularly a nutrition intervention. So for those who may not know what an intervention is, these are programs or activities that are within a program that are designed to help reduce negative or adverse health outcomes. These programs can often would target behaviors that are often overlooked or neglected in Black Americans, like I said, nutrition, or perhaps even behavioral modification. If I were to create a nutritional intervention, it would be conducted at a location where Black Americans feel connected and secure, kind of like with the faith study. It would be perhaps at a church or a local wellness center for a certain period of time. I would also utilize RDNs, clinicians, physicians, or health advisors that resemble the people of this population, because I do feel like that can help build that rapport of trust and also positive engagement in care. And of course, before the program, during the program, and after, providers will constantly check in on their patients to analyze progress and address any questions or concerns that they may have, which can help them along their way towards healing. My second solution to addressing hypertension gaps would be patient-centered communication training for both current and also future healthcare providers. So I believe in this class we did talk about patient-centered communication to an extent. This is basically a communication technique where the patient's inputs are given consideration instead of just the doctor making all of the decisions. My program, it could focus on open body language to show the patient that the health provider is here and is present and listening to them, active listening, and of course, excuse me, shared decision making. These would be conducted at numerous institutions. It wouldn't be limited to just one type or one area. It would be at, of course, medical institutions for medical providers in training and also the current ones, clinics, wellness centers, etc. It would also be taught by professionals who are certified in patient-centered communication. And of course, the content itself would contain things like content regarding scenarios, lessons about reducing medical jargon. So I feel like, of course, if the treatment plan has very complicated steps, methods, or vocabulary, then obviously patients are not going to likely want to engage in that or feel motivated to change if all they see is the complicated vocabulary terms. And of course, cultural sensitivity, just knowing that, acknowledging that a person is more than just their diagnosis. Like I said, that's really the main point of that. I feel like implementing patient-centered communication helps enable providers not only to customize treatments to a patient's identity and their individual needs, but also promote open dialogue between patient and provider. So that way it can potentially limit any breakdowns in communication. It can also build trust with patients. And in the patient's perspective, of course, If they see that their provider is being very open, is concerned about them, and is being relatively respectful, then of course they're going to want to engage more, feel more trusting, they feel seen, they feel heard, all of which are very important aspects of quality care in the journey towards healing. And that's what it's all about. So here are my references in case anybody is curious about not only the two resources that I presented, but if you want to read more about those in detail and the other ones that I presented, then here's a list of those. And with that, that concludes my presentation. Thank you all for listening, and I hope you all have a wonderful semester.